Good evening, everyone. This is a 1 year, 2 months old boy. Was diagnosed at 6 months of age to have a DORV, subaortic VSD, with one additional moderate size muscular VSD with severe pulmonary hypertension, and had underwent the VSD surgical closure of subaortic VSD with PA banding in outside hospital in January 2009 at 7 months of age. But he has significant, currently, in spite of surgery, has a significant growth failure, and there is no weight gain since surgery. The child is currently also on the anti-failure medications, lacisalactone, enalaprine, and digoxin. On examination, weight is 5.8 kg. It was 6 kg at the time of the surgery in January 2019. The pulse is 110 per minute, regular, saturating 97%. There is a midline sternotomy scar seen. Apex is in the left fifth intercostal space, just outside the 1 centimeter outside the mid-clavicular line. S1 is normal, S2 normal split. Grade 3/6 is early systolic murmur in the left sternal border with the mid-diastolic murmur at the apex. X-ray is showing situs soletus levocardia with cardiothoracic ratio of around 60%. Pulmonary plethora with dilated main pulmonary artery, and the PA band shadow is seen. There is a pulmonary plethora. ECG is showing sinus rhythm with rate of around 120 with QRS axis plus 90 with biventricular hypertrophy, and the Katz-Waxel phenomena is seen. On echocardiograph, this is apical four-chamber view showing the dilated LA-LV with moderate TR. On the right side, on posterior sweep of the four-chamber view, we are able to see the defect VSD. And in apical four-chamber, it is measuring around 6 mm. This is the subcostal short axis view showing the VSD measuring around 11 mm. And this is the long axis view with the posterior sweep showing the VSD. There is a mild TR with a peak gradient of 57/30. The 3D image showing the inlet outlet of RV and the VSD below the tricuspid wall, which was measuring around 10.9 mm. So the final impression is status post VSD surgical closure with PA banding in January 2019 for DORV subaortic VSD and additional VSD with the 11 mm residual VSD with no significant IV gradient, moderate TR, mild AR with dilated LALV, severe hyperkinetic PAH. Actually, the patient is also having a bilateral SVC with LSVC to the roofed coronary sinus to RA with adequate biventricular function. And the plan is for cardiac catheterization followed by the VSD surgical closure. Thank you.
Come to AP view and show fluoro. Huh? Are you seeing us
yes,
right
yes,
now?
Yes, sir.
Okay. Now the echocardiogram we will show. Echo live. Echo big. This is today's transesophageal echocardiogram just at the beginning of the procedure. You can appreciate here there is a bang at the inlet crux of the heart. You see the mitral valve has sort of disappeared here, and the tricuspid valve is there, and the VSD is located right at the corner there, that area. Next picture. Now you see that is a dilated coronary sinus on the top, which is draining that left superior vena cava, and the VSD is basically at the crux of the heart. Tricuspid valve is seen, mitral valve is partially disappeared. We are seeing the posterior LV wall. Next picture. So next picture, this is the measurement. It measures around 8 mm. Next. So the laminar flow from the left atrium, left ventricle to right ventricle, there is no gradient across the ventricular septal defect. Next. Next. Again another measurement around 8 mm. Next. There is a moderate tricuspid regurgitation. Next. You can appreciate now the VSD. This color suppress. Color suppress. Okay. Can you see that? Can you freeze it and show them? So it doesn't have a proximal margin. It is located right at the crux of the heart. Color back. So that this is the sort of flow from the left ventricle into the right ventricle, quite laminar. Next. So that is the VSD. Next. So actually, for seeing the VSD, I need to push the probe to the lowermost portion of the heart. This is the long axial view of the left ventricular inflow. No regurgitation. Outflow, no aortic regurgitation. The regular VSD patch has no residual VSD. So that is again the VSD. Show the VSD, doctor, take the arrow and show the VSD. Yes, that is the VSD. Next picture. So that is here. We are getting around 9 millimeters. Show back the picture. This is actually in that long axial view. After we see the LV outflow tract, then we make a rightward sweep and we get into this. I'll just orient below the VSD. Show that picture back. Okay, below the VSD is the right ventricle. Show below. That is the right ventricle. Just go above. That is the left ventricle. No, that side. That is the left ventricle. So basically it is located bang at the crux of the heart. Next. And this is the tricuspid regurgitation. This is before any catheters went in. Next. Track the ACT and tell us the ACT. So the RV systolic pressure was around 70. Next. This is the pulmonary valve. Actually, there was a band that was done by the surgeon in order to restrict the pulmonary blood flow, but the band is not functionally active. You can see the quite wide main pulmonary artery with a pulmonary regurgitation due to the PA dilatation. Next. This is the pulmonary regurgitation jet. We can appreciate that there is quite a severe pulmonary hypertension. So this is the left ventricular outflow tract, the aortic valve with the patch seen. There is no aortic regurgitation. The LVOT, there is not much of a gradient, mild flow turbulence. So this is, go back. This is the regular four-chamber view where we are not visualizing the VSD. You can appreciate the dilated coronary sinus on the left side. The moment we push it in, then the VSD appears, like after the mitral valve disappears. So it is at the crux VSD or a bang inlet VSD. Next. So this is the crux of the heart, and there the VSD is there. Next. So then we again made some measurements. Next. So this is what we got as the echocardiographic finding. Now then, Orakan and myself, I think Orakan, you want to talk?
Well, for me, because there is no rim at all superiorly, so my concern would be if we're going to put the device in, how can the device will stay? So that's one issue. Second issue would be the heart block, because it may close to the AV node. But again, discuss with Shiva. Maybe we can avoid that. So to be honest with you, I mean, at home I may ask the surgeon if they can do it. But here, because I think the surgeon try as best as possible that they can do it in order to just find this out, but he could not. So I think that's the reason why we try to attempt it.
Okay, so what the first, actually it's a very questionable, people might question, it is bang on the crux of the heart, but in my belief, I think the AV node will be coming on the anteroseptal commissure. It will be at the anterior end of the septal tricuspid leaflet and not at the posterior end of the septal tricuspid leaflet. This VSD is located at the posterior end of the septal tricuspid leaflet, and I feel that this VSD probably may not, if you put in a device, may not cause, even though during our looping, couple of times we got into heart block, but that was due to the tension of the atrioventricular loop that we created. In fact, we were predictably able to loosen the loop and then get the child back into sinus rhythm, and if we tighten the loop, what size? Same thing, 15 by 12 is there in Occlutech. Okay, fine, go ahead. Yeah, please. So, sorry about it. We felt that this area, since it is a post-operative patient, we can give a trial. In fact, the surgeon is so nice that he is coming and standing behind us, the primary surgeon who did the surgery. And I'll show you the angiography. Show the angiography big. So what we did was we put in a catheter into the right and left pulmonary artery and into the aorta. Aortic pressure and LV pressure, aortic pressure and pulmonary artery.
We are not able to
Show the angiogram. Cut the echocardiogram and show the angiogram. Take away our faces. Remove us. Okay. So the aortic systolic pressure and pulmonary artery systolic pressure were the same. There was no difference between aorta and pulmonary artery pressure. The deep into the left pulmonary artery, it was 100 systolic. Aorta was 100 systolic. Right pulmonary artery was 90 systolic. The diastolic pressures in both the pulmonary arteries was about 20 less than the aortic diastolic, and the mean pressure was 10 less than the aortic mean. Then we did the LV angiogram in a hepatoclavicular view, which is LAO 40 and cranial 40. We could appreciate, freeze the picture. We can appreciate the freeze. Okay, go back, go back, go back, go back. Keep on going back. Go back. Just go back. Back. Fill now from frame by frame. That is the jet. No, just come previous. Next. Okay, that broad jet that was coming, immediately it envelops the tricuspid valve. You can see the negative round shadow of the tricuspid valve. You can appreciate here, this is actually inferior part of the tricuspid annulus. It is not at the superior end. Just can you go back one frame? Yeah, that is the VSD. Can you point it out with a marker here? Do you have any marker there? Okay, so there is no marker, but can you appreciate a jet that was going from the LV to the RV?
Yes, we
A
can.
black color. Okay,
Yes, we are able
so that was the ventricular septal leaf. Yeah. So then the next step that we did next. So run it. Okay, so then we crossed the VSD. Next. Run it. Our intention was to, we were thinking, since the patient is having moderate tricuspid regurgitation, which I feel may be due to pulmonary hypertension, if we put in a device through the venous side, a cable will be across the tricuspid valve, and there will be tricuspid regurgitation. We will not be knowing whether it is through the cable, because of the cable, or otherwise. So we transiently thought of retrogradely going and closing it. The issue about a retrograde closure is, we have to put in a large arterial sheath. We measured a maximum of around 9 millimeter on one of the views. So our decision was to go for a 1210, right? Okay, 1210. Yeah, 1210. 1210 multifunction occluder, or a 12 millimeter muscular VSD, 10 or 12 millimeter muscular VSD device. So then we decided that since the child is too small, it's only 5.8 kilogram, so we will rather go for a softer device multifunction occluder. We advanced it through a 6 French sheet, and we found that 6 French compatible.
May I interrupt?
So our then next intention was, yeah, please.
Sorry to interrupt, sir. So maybe know the hemodynamic data and the parameters for operability.
I told you, aortic pressure and pulmonary artery pressure was systemic.
Because
But the PA diastolic is 20 less than, PA diastolic is 20 less than the aortic diastolic. PA mean is 10 less than the aortic mean. This child is thoroughly having a left-right shunt only on echocardiography with saturations always 99%. Child is in heart failure.
Any comment
LA
on
and
the
LV are
PVRI?
dilated. We did not. QP, QS and all I could not take because it's an intubated child on oxygen. We cannot get any sort of proper oximetry. The child is intubated.
I think
But
considering
looking
the
at
age of the child, the
Yeah.
symptoms and the
Cardiomegaly
saturation,
symptoms,
in most likely the child is still
Would you like to do a
in the
QPQS?
operable range.
He's having severe failure to thrive as well.
X-ray
These
also
all
showing the cardiomegaly and the plethora. All signs were in favorable.
Okay, we can proceed, Dr. Shiva.
Varakan, would you like to do
Yeah,
a QPQS?
Clinically, the patient is on heart failure, so definitely if we can get the number, that would be good. But in terms of the clinical, I think it's justified to do something with that VSD.
Intubated patient, so oximetry I felt was not going to be giving any reliable data. The PA diastolic and the PA mean was 10 and 20 less than the aortic diastolic and aortic mean.
Actually, to comment, so this is Prashant here. Actually, we do all our
Yes.
oximetric data in general anesthesia. The reason is usually it's a prolonged procedure and takes almost 1.5 to 2 hours to do all the steps. Just if we can get the saturation FiO2 to 21%, I think it gives a reasonable data. So maybe general anesthesia is not a contraindication to to doing an oximetry. But anyways, I mean, considering all the features, the child looks still operable.
Okay. So what the next step is, show the next. So we decided to go and pass a retrograde catheter. However, the problem was we were not able to advance the 6 French Mullin sheath into the VSD. Next. So next. So then we decided to take an AV loop. Then next. Next. Yeah, I'll cut it short. So now finally, the position right now that we have is show. So there is a AV loop. We have got a venous catheter that is going through the RA, through the VSD into the left ventricle. We have not removed the loop. The aortic pressure you are watching there, change it into yellow color. Okay, yellow color so that everybody can see. You cannot change. Okay, it's 104 by 48, 45 with a mean of 66. Varakan, what you tell something? What do you
that's
want
fine.
to do?
I think I follow you, and I think that's now we are in the right position to do something. The key will be, should we just take the Y out, and without body Y, can we do it? Unfortunately, what we have
Get a
here is a
short
7
6-French
French
sheath.
Mullin sheath. So if you're
Short
going to
6-French
use the
sheath.
10 by 12 MF4, it's likely that it will take 7 French sheath.
Flush.
So I think we cannot afford to have the body Y, I mean with the 035 Ys. So hopefully once we take the Y out, and then when we deploy it, it will be okay. So pray for us.
Can you give me a vascular
So
plug
can
cable?
you show the device or what?
I'll show it. Can we
Okay.
load it on a vascular plug cable?
Yeah, we should.
I think
Because
get a
the cable-
vascular
the
plug
cable
cable,
is Tuesday.
AVP cable. Now show the device bigger. So this is Nageshwar Rao device. So it has got a high pressure disc that I am holding with this hand, and a low pressure disc that I am holding with this hand. There is a fabric. This is 12-10. So the discs are 16 millimeter on either side. We do have a concern when we are going from the antegrade. We will be like, sometimes the entire RV disc may be coming on to the right atrial side, and it will form a button on the septo-posterior commissure. Our intention is to push it beneath the tricuspid valve. If you take a rigid PDA cable, what is this? Okay. If you take a rigid PDA cable, one of the concern is we might not be able to bend it into the right ventricle. So I am loading it on an AVP2 cable. No, this is not, it's too big. It's too big. Okay, get me another AVP2 cable. The screw is going just very big. Okay, this is better. No, but I am just checking. Okay, so this is coming better. So my intention is, after I get it, if suppose this is sitting on the septo-posterior tricuspid commissure, I will advance the guide wire towards the right ventricle and try to flip the device into the right ventricle. So I'm loading it. on a 6 French sheath. We are going to lose the, get out of the AV circuit now. Dr. Varakan, can you get it out?
I'll take the wire out.
Which way?
Go this way because this is softer.
Okay.
Okay.
Hmm.
Bring the wire back.
Yeah. Okay. Can you echo big? Is it still the temperature issues are there? Okay. So till the time we take the device inside, then you can be there. One of the problem that the echocardiographer Dr. Raghuram is facing is the temperature of the TE probe, the pediatric TE probe is getting heated up, and so it is giving a warning for him. Would you like to shift it into a pigtail here for French?
Yeah, that's fine.
Yeah, so put in a
Turn the
wire
wire,
and then we
please.
can go ahead.
Sir, just one
Give me
question. Is there
yeah.
any other option of a device which you would like to consider, or
Wire
only the
first,
double
wire.
disc device?
What other
Like
devices,
a-
like ADO type of device?
Yes, ADO type of device, because it may not have the disc.
What
on
about ADO type of device? ADO 1 type of device?
Well, it's long neck. I mean, the shaft is long, so I think it won't accommodate with the short distance of the AV valve to the hole. So I will not use it.
One more thing is right now the aorta and PA pressures are sort of systemic. Advance away. In fact, Prashant was telling that he would be happy to see a PVRI value and all. So I think a double disc will make sense rather than a single. It is definitely not a restrictive VSD. It is a very large VSD. Maybe there is justification more for a regular
It's about to break.
double disc device rather than a single disc.
Yeah, in view of the pH, we can consider the double disc device, but the entrapment of the tricuspid valve or anything in the disc on the RV side
Yeah,
may have some
Varakan,
of the higher
Varakan,
chances.
what would we think about a double disc? The point is ADO1 will have an advantage that it doesn't protrude through the septotricuspid, septoposterior commissure too much. But in terms of security, we will feel very jittery, right?
Yeah, and also I think the neck is quite long. It will touch the tricuspid valve anyway.
So
other-
pH, if we consider this
yeah.
is like a
So,
hyperkinetic pH,
Okay,
Can you have another new one?
can I have one word?
why-
Actually, we are trying to get the pigtail into the left ventricle. However, Dr. Bharat Dalvi, Dr. Biswajit, and Dr. Tin are ready with very, very interesting case from the other lab, and so they want me to temporarily stop this transmission and switch over to the other lab.
Just a question, why not muscular VSD device? Bigger
Sir,
seat
there is a question.
We
But
thought that will be.
taken up. Means seat you can increase the size, maybe from you are going from the venous side, so even 8 will go, no problem.
this we are considering from the arterial
In a
side.
5.8 kilo
no,
child,
no,
the muscular VSD will be a
From
little
the
bit more
venous side.
bulkier. Okay, so what happened was you show the angiography. Show a little bit before, before. Okay, so this is where we left you. So the sheath was in the left ventricle. Next picture. So run it. So this was a 1210 multifunction occluder device, okay, next. Okay, next. Okay, so the device was deployed like this. Show the echocardiogram now live. So the device is across. The concerns now are there is, as we were thinking, there is some tricuspid regurgitation. Can you get the tricuspid regurgitation better by maybe parasternal long axis or so? You try to see away from the, yeah. Yeah, okay. That is, no, you have inverted the probe. Your pulmonary artery is on that side. What view is this? See, parasternal short axis. Keep them on. Yeah, please, yeah. Parasternal short axis. This one, give it to Dr. Amitabh. Parasternal short axis. Yeah, that's pulmonary artery. Yeah, this is the RV disc color now. So that is the tricuspid regurgitation.
Maybe over the period of time it may regress because all chambers are dilated and there is a high pressure in the pulmonary artery. If we leave him alone, it may regress gradually over a period of time.
Who is this so optimistic? Like I like your comments.
No, it is always there. We have seen 2 patients with complete heart block. We also got a heart block. Then we thought maybe edema. Gave some steroids. Within a week, it completely disappeared, became normal sinus rhythm. And all patients within 1 to 2 months, within 6 weeks, all chambers
Is it Dr.
regress.
Kavita Chintala?
No, I am Dr. Geeta Subramaniam, Professor of Cardiology, Banaras Hindu University.
Oh, madam, warm welcome to the forum.
Yeah. You
Madam
see?
gets the Banaras Hindu University in Varanasi, the cardiology program, and she was the head of the department of cardiology in Madras Medical College. Madam, thanks a lot for
We
coming
have
to our
finished
meeting.
112 cases of
And,
device
we
closure
feel
without
blessed.
finished 112 cases in a non-metro city, though it is a big atrocity with limited facilities, without any mortality, morbidity, and all are doing very well.
Shiva, still the...
And
I know,
we
madam.
have to thank
Madam is
Dr.
actually staying in
we
the-
have to thank Dr. Vijayalakshmi, Dr. Edwin, and our Dr. Avasti. Avasti has become part of our life.
Shiva, you are still... cable is
Yeah,
there, no?
yeah.
Shiva?
Which one? Which one? Cable is there. Yeah.
Yeah. Probably,
Now, hemodynamics big. Show the hemodynamics big.
maybe I think TR.
Hemodynamics big.
TR also. Maybe I said
Some
recency.
entrapment of the.
Now the question is, suppose I release the cable, whether the tricuspid valve entrapment will become better, because now the cable is maybe splinting some part of the tricuspid valve.
Yeah, I
Why,
think
sir, as we can see, PA pressure has come down. Why not changing over to ADO1 rather than having a doubt of having second disc and whether it will release the entrapment or not?
Yeah.
Because still that
The issue
concern.
is like whether I'll be able to predictably go back and again into the LV apex. I'm not sure. We can try to recapture. Huh?
I think we can do recapture, change it, but I'm not sure whether, first of all, if we can, do the thing that we did previously or not in terms of the positioning of the system, the delivery sheath. That's one thing. Second thing, I think ADO1 is more rigid than this. I'm not sure whether if it that rigid, it may cause other problem or not. Third would be, PA pressure comes down. So
Hemodynamics big.
if there's TR, I don't think that TR gonna create a problem. I can't guarantee definitely that TR will getting less, but it's likely to not getting more. So so that's all I can do. If I were Shiva now, I will release it.
Shiva, one question,
Because
one
I
comment.
think TR is manageable, and that's the thing that we cannot avoid with this device. But I think that's stable enough to release.
Shiva, one comment.
I am. Yes, Dr. Krishnamurthy.
Oh, this double disc device I think is more stable because it baffles me even now how this device is sitting there without a superior rim. So a double disc device in such a situation, even with a compromise on the tricuspid wall, with the reference to stability is more stable than.
Totally agree, sir.
I'm surrounded by all intellectuals here. Dr. Tin Goyen,
Also,
Dr. Supapon. What is your opinion, Dr.
Sir, Srinivas here, sir. Hello?
Release?
Sir, have you done
Yes?
an LV
Yeah,
angiogram?
Srinivas.
LV angiogram, sir, how does it look?
About to.
I can do it, Srini, but see the
If LV angiogram looks good, I
device
think-
is possibly secure.
Yeah. No, if there is no residual
No,
shunt.
but
then-
LV angiogram will not stop.
Correct.
LV angiogram will not stop immediately. No, this is a very flimsy device. It will take some time to close.
Now,
I can give some contrast. Let me see.
Now the only concern we have is the tricuspid regurgitation. I think that is a small risk that we
Hands
have
up.
to take
Hands
and release this device. So if not, I don't think so any other method is there to avoid this uncertainty about the tricuspid regurgitation, sir.
Also, the PA pressures have come down, but they have not normalized. So we would, I think, still a double disc device would still be a better than an ADO1 here.
Totally agree, sir.
Can you get me some other view so that I can enter?
LAO, maybe.
Little LAO. Go to LAO 40, cranial 40. The child is very small. So what is happening is whenever we are trying to manipulate, the rhythm becomes very abnormal. Child is about 5.8 kilogram. Okay, come bus. Inject. Give about 8 ml at 12 rate. The T cable a little bit up. Yeah, collimate so that we don't see the mouth, the tooth and all. Yeah, yeah, yeah. You can the T probe can little bit come up so that nothing comes in the way. That's it. Okay. Once again. Okay.
Sini.
Position is okay, but in terms of residual flow, it will be tough to predict today.
Well, what I see inferiorly, it looks as if the device is not sandwiching, not stenting the defect properly.
Sir, is-
Maybe this device is a little bit, like the same diameter with the hole.
Is there an extra device shunt from the lower
Try
side?
this 1210 PDA device, because that will be more self-centering. We'll just try to see, resheath and see whether we are able to get it. Let me see. What do you say?
Let me listen to the murmur.
Yeah.
Super, if you could
Dr.
listen to
Shiva?
the murmur.
Yes,
please.
yes,
Dr.
madam.
Kavita here.
Yeah.
I'm not as optimistic. I don't know what.
Yeah,
is going
Dr.
to-
Kavita.
I'm not as optimistic. I don't know what is going to hold without the superior rim. That is one. And with the risk of damaging the tricuspid valve and heart block, I would probably send this baby to surgery.
Yeah, actually, this is you
murmur
will be
is
knowing
there,
that
right?
there was one surgery already done. Actually, if you put in the device and suppose release it, and if there is a tricuspid regurgitation, the surgeon can even try to take it tomorrow or day after tomorrow.
True, but more than the TR, I think it's kind of entangled in the tricuspid valve, and inlet VSDs we know, don't take very well closeness to its valve.
I think we'll try. Now that the PA pressure is coming down, we'll try ADO 1 and see, because that will be self-centering.
Can I see your side?
Dr. Shiva, will you we continue with the talks?
Yeah.
पूरा LV में हूँ ऐसा लग रहा है.
Yeah, please go ahead. What is the problem?
So we left you after we did angio on the left ventricular side. So if you can see the angio now, right?
We can see.
Yeah, we can see the angio.
Yeah, so a couple of things for that angio. Yeah, the first one is what I thought was for some reason the left ventricular disc is not completely well opposed to the septum. And also another thing, that there's a small apical muscular VSD, which is shown here very nicely. And also, if you can have a look on the echo, echo, please. Raghu gonna show you. Yeah. So that one, that was when we left you. Again, just showing the TR is quite more than moderate, definitely. So we try our best to just maneuvering the cable in order to see whether it will be coaxial of the left or the right ventricular disc to the septum or not, in order to just abolish that TR. So definitely it won't go away. And it looks as if it even more, in terms of severity. And also we listened to the murmur, and the murmur was more than grade 3. So I think at that time we thought definitely we need to do something. We can't just leave it like that. So we finally decided to recapture it. Please, next please. So we recaptured that. Yeah, so we recaptured that device. And Shiva actually very nicely pushed the cable, pulled the cable while engaging the sheath onto the left ventricle once again. So with that, we didn't lose any position of the sheath. And then we decide whether what should we proceed to the same device, or as the previous panelists mentioning about using the single disc device, which is ADO type device. So that's why we thought probably if we try the same thing, it will come back with the same result. So we decided to use the LifeTech PDA device, which is actually 10 by 12 millimeters, just similar diameter with the device that we use for the MF4. And this is what we had during deployment of that PDA device from LifeTech. Next, please. Next, please. Next, please. Yeah, can you run that? Yeah, so this is much better in terms of the positioning, because it's more self-centering. And as you can see that now Shiva did try to pull it back, opposed to the septum, and echo also show that it will oppose, and then just slightly Shiva just unsheathed. And you can appreciate very nicely that the waist is there, and also the right ventricular side have flare. So it means that for some reason that position is quite stable for this device. Next, please. So then we check angio again. So it's confirmed that the waist is there, and the left ventricular side quite stable, no issue on the left side, and also the TR. Please have a look on the echo. Yeah, so TR severity is definitely less than what we use the MF4. Well, it's there definitely. It didn't go away. A couple of reasons. First, maybe because of the cable. Second, to be because of the proximity of the device to the tricuspid valve. But that is what we expected. So the question to be whether we accept that or not. So we discussed quite comprehensively. So we thought probably because PA pressure is coming down, and even if there's TR, that would not be a problem. I mean, in terms of having the right side heart failure whatsoever. So then we decide just to release it. So next, please. Next, please. Okay, so backward. Okay, so that one is when we did release. So we're quite concerned a bit, because we thought that the device should be something more, how can I say, horizontal, but that one looks a bit more, longitudinal. I mean, tilting quite a bit. But we check also the echo. Please show the echo. So that's the last one, right? So again, just to show you that TR is there, but I think it's acceptable, and there's no issue on the tricuspid valve excursion. So valve is moving well. So we check also the RA pressure. It's about the mean, it's about 13, right? 13, 14, something like that. And PA pressure was mean is about 40 to 50. So we're quite happy with that result. So we finalized, just stop the procedure. We didn't decide to do the apical muscular VSD device closure, because I think that is not a big issue at the moment. So that's kind of summarized that we had.
Thank you.
That's great.
Thank you. Yeah. I think we'll go with the next session, isn't it? I think we'll
Thank
go with
you.
Thank you, Varikan, thank you.
Thank you.